Hello, everyone. Good afternoon. Hope you're all doing well today and staying dry. Welcome to today's webinar, which is the sixth in our series of partnerships with the San Bernardino County Department of Public Health, focusing on COVID-19 vaccines and health equity. Today's webinar is COVID-19 vaccines and the fight for equity. Where are we at and what have we learned? I'm Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. I'm very excited to introduce our presenters today. So we just want to remind you to please keep yourselves on mute if you aren't speaking. And we will also be taking questions following the presentations. So we invite you to go ahead and submit your questions on the chat feature on Zoom, or you can also use the raise hand icon at the end of the presentations if you want to ask and be more interactive. But we'll get to all of that as soon as our wonderful presenters here finish with their sessions. So first off, I'm very pleased to introduce Michael A. Sequeira, MD, Health Officer, San Bernardino County Department of Public Health. For the past 30 years, Dr. Sequeira has worked in leadership roles at the local, state, and national levels, including as Regional Director of 6 of the hospital emergency departments. He's past president of San Bernardino County Medical Society, yay, 2016-17, and he currently serves as a delegate to the California Medical Association's House of Delegates through the Medical Society. He's a member of the steering committee of the Inland Empire Opioid Crisis Coalition, which he was instrumental in developing as far as an educational program for opioid prescribing and overdose treatment and prevention in hospitals and the community. He also serves as National Risk Director for Vituity Healthcare, where he has been charged with keeping providers current with the latest clinical and research data in COVID-19. Welcome, Dr. Sequeira. And I'm going to go ahead and introduce Chelsea and Stacy at this time too, and then you can all just get started with your presentations. So we are very happy to introduce Ms. Chelsea Koski, MPH. Ms. Koski is an emergency response and special projects coordinator at the San Bernardino County Department of Public Health. Within this role, she oversees a variety of projects, but is currently primarily overseeing the COVID-19 response, including testing and vaccination services. Ms. Koski holds a master's degree in public health from Cal Baptist University. And we are also very excited to welcome Stacy Davis. Ms. Davis is the Health Equity Program Manager for Department of Public Health, San Bernardino County. She's been active in managing clinical quality measurement data collection and working collaboratively to develop data-driven clinical practices and population management strategies. She has 10 years of experience in infectious disease control and epidemiology, outbreak investigation, project management, and program development. So we welcome you all, and I will turn it over to you. Thank you.
Thanks, Allison. It's again a pleasure, and of course, part of my blood is the medical society and the profession of medicine. So it's my pleasure and honor to speak to all of you. And I think we've got a great presentation today. I'm excited to introduce some of the stars of our program, and there's so much talent that's in public health now, and Stacy and Chelsea. So they're going to help me present this, and what we're going to do is basically talk about where we're at, and we really want to throw in an emphasis on equity because that's really, really important. And Stacy, as you heard, is our health equity program manager, so she gives us some great insights. And Chelsea really is the operational manager of our COVID program and handled the vaccines, and they're both just excellent, and so it's a pleasure, and I'm real proud to co-present with them. So what we're gonna do now is just turn it over to Stacy. She's going to take us through the first part of this with just an overview and some statistics with an emphasis on equity. Stacy.
Great, thank you, Dr. Sequeira. So yeah, so thanks for having us. What we thought we would do is to sort of give you a picture of where we're at now, and then perhaps, so we'll share some data with you, and then also, as Dr. Sequeira mentioned, look at it with an equity lens. So this first graphic is just kind of showing you in San Bernardino County what our case trends have been of late over the last 6 months. So you can see our case rate is down significantly from our peak in early December Now we're experiencing about 100 cases per day in San Bernardino, down from our peak of over 900 cases a day back in early December. And our case rate of 4.7 cases per 100,000 is actually below the California 7-day average right now. So those are good things. Also, just throwing into the mix, of course, many of you and lots of folks have greater access to over-the-counter test kits right now. And as you know, positive results from those kits don't get reported to us and counted in our case numbers necessarily. So that's a lot of our data of late is reflective of that as well. So if you could hit the next, thank you, Chelsea. And then the next, just kind of looking at this in terms of the percentage of our cases and the distribution of cases relative to our population by race and ethnicity in San Bernardino County. So the blue bars show the percentage of our population in San Bernardino County. The yellow bars reflect the percentage of cases in our county over the last 30 days. And you can see that while small, Black African Americans are still overrepresented in terms of the proportion of cases, as are Latinos. And so this has obviously been, was exacerbated more during some of the peaks of our pandemic, but we still see some of those differences. And then in the next image, we're looking at the rate of cases now per 100,000 by race and ethnicity in the last 30 days for San Bernardino County. And as compared to whites, you can see that Asians, Latinos, and African American populations are all experiencing higher case rates disproportionately. However, we're all below the statewide case rate per 100,000, as I mentioned earlier. So we can go to the next slide. Okay, and so we wanted to share with you a little bit of information about the severe outcomes of COVID, mainly hospitalizations and deaths. So this is our most recent data, which demonstrates 115 COVID-19 hospitalized patients in our county. Of course, that's down from our peak of over 250 a day in mid-December, which is good, and overall hospitalizations have been declining. And then on our next slide, you can see that we've had most recently, as of March 15th, 17 patients hospitalized in ICU, principally for COVID-19 infection, down again from our most recent peak in late January of over 60. And we've had a fairly steady rate of hospitalizations in the ICU for COVID over the last several weeks. And then in the next slide, you can see that we've had no confirmed deaths in the last 30 days, although we know that there's a lag in some of this data. And then I'd like to show you a little bit more on the next slide about the proportions of hospitalizations and deaths by Healthy Places Index, so our HPI quartiles. So many of you may be familiar with this metric. The HPI index is becoming more and more widely used. We generally use it and we talk about HPI quartiles. One HPI quartile 1 being the lowest quartile, and we usually talk about census tracts or zip codes. It's a composite index which takes into account lots of different factors, including things like transportation, access to healthcare, education, things like that. So really it's an indicator of the social needs of a community. So generally those in communities that are ranked as quartile 1 are in more disadvantaged communities or under-resourced communities. And if we look at cases or hospitalizations by census tract HPI in San Bernardino County, we can see that nearly half of our cases or hospitalizations are occurring among those in more disadvantaged communities or in HPI quartile 1 census tracts. And then on the right, if you look at mortality rates per 100,000, this is by race and ethnicity and HPI quartile, you can see that not only are there differences by race and ethnicity overall, but as we look at HPI quartiles, even within a specific race or ethnicity, you can see higher mortality rates, among the lower HPI quartiles. So quartile 1, which is shown in the dark blue, consistently across all racial and ethnic groups, we see higher mortality rates among folks who live in more disadvantaged communities. Okay, and then the next slide, I wanted to give you a brief update on our variants. So this is a very busy chart, but really is meant to show you, the colors all signify different sublineages of the SARS-CoV-2 virus. And many of that sublineages are actually different types of Omicron. And so the distribution has definitely changed over the last year. We still have somewhat incomplete data because this data also lags for February. But you can see that the majority of variants circulating are sublineages of the Omicron variant. And really, there's just recommendations, of course, as you know, to prioritize use of Paxlovid and remdesivir for treatment of mild to moderate COVID-19 and outpatients at risk for disease progression, specifically for these types of subvariants. Okay, and I think the next slide, I wanted to share with you a little bit of data from an equity perspective around our vaccinations in San Bernardino County. So you can see here that the top box, the 4 boxes on the top left, are really showing our overall vaccination rate is about 57.9% for the primary series. The bottom left box is showing about 53% of primary series folks who have a primary series and a booster, and then 17% for a bivalent booster. The 57 or 58%, nearly 58% is lower than the California average of 72 or 73%. So we're far below where we'd like to be in terms of at least primary series vaccinations. And then if we look at primary series and booster by HPI in California and San Bernardino. So I think on the left is San Bernardino. Chelsea, that might come up in a different animation. There you go. Okay, and so the primary series and booster, this is stratified by HPI in San Bernardino County on the left. So you can see that vaccination rates in the lower quartile communities are much lower than the vaccination rates in our higher quartile, more resourced communities. So there are stark differences that way as well. And that pattern is reflected across California. If we look at this as compared to our HPI quartile populations in California, though the bars are bigger and we have a greater percentage of California residents living in quartiles 3 and 4 than we do in San Bernardino County, vaccination rates are still lower in our lower quartile populations. So this is definitely a concern as well. And then finally, I wanted to share with you a bit more stratification by race and ethnicity and then age group. So again, this is some data showing vaccination rates over time specifically for the primary series. So you can see age groups in different colors. Of course, some of this is lagging. The pediatric age groups don't start showing increases in vaccination rates, of course, until the pandemic when those vaccines were licensed for use. And then down below, if we look at vaccination rates by race and ethnicity within those age groups, we can see that there's definitely stark differences pretty consistently, that we have lower vaccination rates within age groups for African Americans and Latino populations. And specifically, our county has been really focusing on trying to increase vaccination rates in our pediatric populations, so those 6 months to 17 years of age, because we have very stark differences and huge disparities within those age groups and by race and ethnicity as well. We've actually formed a couple of work groups, vaccine equity work groups, focusing specifically on increasing pediatric COVID-19 vaccinations for Latinx and African American children and their families. And we've designed and collaboratively drafted some of the goals that you see here on the right, where we're talking about increasing vaccination rates and really reducing disparities among these subpopulations. Okay, and then I just wanted to make a note about data. and how that plays into equity. And so wanted to share with you, we have some measures of completeness for our data. What we measure is what we address. And so, you know, a lot of times when public health, especially, we're asking for reporting and we're doing generally passive surveillance, you know, the data that is collected and reported to us is really critical for us being able to identify disparities and inequities in different groups and different areas of our the population that we serve. And so wanted to share with you some data by race and ethnicity. So you can see that if we look at test data, that we have about 35% of our test data is missing data by race and ethnicity, which means that we don't really know the accuracy of what we might see in terms of positivity rates by race and ethnicity, for example, may not be great. Similar to case data, where we have about 20% of data is missing race and ethnicity. We haven't had any deaths in the last 30 days, so that is not reflected here. If we look at sexual orientation, we have over 80% of our data is missing data by sexual orientation. We saw that as really a critical piece of information, of course, in our most recent monkeypox outbreak. And then gender identity. So we have some great data on that. We're doing really well in terms of reporting that, but it is critical. You know, it's something that we think about in terms of how we ask and record that data. Of course, you all are familiar with collecting SOGI information, but we're really reliant because of our passive surveillance systems for the most part on the quality of the data that gets received and reported to our system. So wanted to share that with you and make a plug for good data, making it easier for us to identify and address health inequities. And from here, I think I will transition it over to Dr. Sequeira. Is that right?
No, I think Chelsea next.
Chelsea,
Yeah,
okay.
it'll be me. Thank you, Stacy. So as Stacy, provided some vaccine data, I just want to give a mention to what vaccines are actually available in our county and which are, EUA approved or have full FDA approval. So as you know, EUA is a method to facilitate the availability and use of medical countermeasures, including vaccines in times of emergencies. And full FDA approval takes place when enough data is there to demonstrate that the vaccines are safe and effective for most people who receive them. So at this time, the vaccines that have full FDA approval are only Pfizer 12+, and then Moderna for 18 years and older. The remainder of this long list of COVID vaccines remains under EUA. And we don't foresee that changing anytime soon, or at least haven't heard of any updates as far as FDA approval for the remainder of the vaccines. And so, just wanted to give a current status of COVID-19 vaccines and boosters, and also start looking ahead at what's to come for these vaccines. COVID vaccines continue to be available for individuals 6 months and older. The primary series remains as a monovalent doses, and the booster vaccination is bivalent. Recently, the FDA authorized and CDC recommended the use of bivalent boosters in those 6 months and older, and completed a 3-dose monovalent Pfizer primary series. So, as as COVID vaccines continue to get authorized for different age groups, and the boosters continue to get authorized, it seems to get more and more confusing for that vaccine schedule. So kind of looking ahead, we have heard that primary series is to transition to bivalent doses, and monovalent doses will sunset. The timeline of that is unknown at this time. We do know that the FDA and CDC have met, but there haven't been any decisions confirmed or made on those. Another aspect is the Moderna 10-dose and 5-dose vials of monovalent products for individuals 6 years and older will not be available due to their product expiration. This will occur in early April. So coming up here very soon, as we are looking at these products, a lot of expirations are not being extended, and therefore the products are kind of sunsetting, and also ties into that transition into bivalent doses moving forward. We're also looking at COVID-19 vaccines to become commercialized, which we're expecting that in anywhere from May to fall of 2023. And this would essentially complicate coverage landscape, and especially for those that are uninsured. We are also looking at the likelihood of a fall booster of COVID-19 vaccines, and possible vaccine requirements for healthcare workers, and both timelines are to be announced on those as well. So the efficacy of vaccines. So vaccine effectiveness is measured of how well vaccination protects people against outcomes such as infection, symptomatic illness, hospitalization, and death. This is typically observed through observational studies, specifically designed to estimate individual protection from vaccination under real-world conditions. So I just included a couple of links here to the most recent MMWR reports, and also the CDC data tracker for vaccine effectiveness. And I think I will hand it over to Dr. Sequeira if you want to expand on this at all.
Thanks, Chelsea. And I've actually heard within our community and also nationally that, geez, there's a question about whether or not the vaccines work yet. I think it's really clear, and we're providing a lot of evidence on this, that they clearly worked, and in fact, vaccination and the vaccine is by far the most important reason that we're pulling in getting control of this pandemic. So, I appreciate this data, and there's a lot of good reports there as well. So just to point out one other quick thing, FDA full approval is what's going to happen if we privatize, so that anything under EUA is not going to potentially be available. So there will be a rush to try and get full FDA approval. Otherwise, on important things like Paxlovid, even if it's not FDA approved, I'm sure they're going to continue the EUA. This is the emergency use authorization. Chelsea?
Awesome. Thank you, Dr. Sequeira. So as Stacy mentioned, the importance of data, so wanted to include some data points here on efficacy of the vaccine. So, just to pulled straight from the CDC, looking at rates of COVID-19 deaths by vaccination status, you can see the black line at the top are those that are unvaccinated. Blue line is vaccinated without an updated booster, which is a little higher than those who are vaccinated with an updated booster. And as you can see, people are 7.9 times more, have lower risk of dying from COVID-19 compared to unvaccinated people, and 1.7 times lower risk of dying from COVID-19 compared to people vaccinated without the updated bivalent booster. And then, as you can see here, there's similar trends with cases by vaccination status as well. Here. And so transitioning over from vaccines to COVID-19 therapeutics, so there have been recent changes to what therapeutics are available. So currently the only therapeutics available for ordering is Paxlovid and molnupiravir, the two antiviral treatments. Monoclonal antibodies, the pre-exposure prophylaxis Evusheld have been deauthorized for use due to the ineffectiveness against Omicron variants. And we are also expecting Paxlovid to become commercialized in May to fall 2023. So with that, once the federal supply of Paxlovid is depleted, it will transition to the commercial market, and consumers may face cost sharing requirements and supply and access constraints, so mostly affecting those that are uninsured. And then I'm going to hand it over to Dr. Sequeira to speak about efficacy on the therapeutics.
Thanks, Chelsea. Yeah, and it's no accident, and it's actually virologic and molecular a basis for why Paxlovid and molnupiravir. I don't know where they got Lagevrio. I have no idea how they got that name, but anyway, why they work. But it's clear, and they've been very effective in reducing hospitalizations and deaths in all age groups. But because of the relative paucity of supply, it's really particularly emphasized in our immunocompromised patients. So there's really no argument, and the reason is that these agents work as neuraminidase inhibitors. So they work on the RNA polymerase, and they insert nucleic acids to create errors in replication, and the virus dies off. They're not anti-spike protein. So remember, we had sotrovimab and all those monoclonal antibodies. Well, those are all monoclonal antibodies towards the spike proteins, and what we've seen is this amazing capacity of this virus to mutate. So the neuraminidase inhibitors continue to work, and there's an IV one, remdesivir, as well, that we still potentially have available that you can use for sick hospitalized patients as well. So clearly work. And a couple of things I wanted to throw in. We don't. Not on our slides, but some of the myths on Paxlovid. It's really important for CDPH and CDC and us that the providers, and I'm speaking to the medical society providers, all the doctors and providers in the community, that we get Paxlovid prescribed as quickly as possible. And remember, it has to be started in the first 5 days. And there's a myth that you shouldn't give it for mild to moderate disease, and that myth is wrong. And it's clearly been shown that even with mild to moderate disease, number one, long COVID does occur with mild to moderate disease, and two, it still has a significant alleviation of hospitalization and death. The other thing is, I'm not high risk, or my patient's not high risk, and it's very clear that most. I always err on just prescribing this, and when you look at the high risk areas, most of our patients could probably qualify for that. And the other myth is the side effects and the rebound, and there's clear-cut evidence now that from CDC that rebound occurs just in natural infection, and that really it does occur more frequently with Paxlovid administration and intake, but at the same time, if you do have a rebound, there's minimal to no progression to hospitalization and death. So it's really important to know this, and it's really important that we get the providers, if your patients are calling, and I really urge you to get the prescription in as soon as possible to the pharmacies. To warn them about the bad taste in their mouth. I've actually had it, and it's a bad taste. So, okay, so we'll go to the next slide, Chelsea. So what I want to do now is transition into, I'm going to cover a lot. we want to end at about 5 after 1, just so we have some time for questions. So, these are the kind of lessons learned that, about COVID, and there's many more actually. So I want to talk about, there's a lot of discussion now about what was the source of the outbreak. Talk about this Cochrane review, which is a meta-analysis that came out about basically incorrectly assuming and concluding that masks don't work, and the method of spread and the communication. So yeah, as we look back, we can look and see our errors, and also understand why our errors occurred. So next slide. This is the raccoon duck. It's kind of cute, isn't it? It's endangered, and it is a canid in the dog family, and this is the strongest evidence so far that actually that COVID-19 is a zoonosis coming from animals. There was a theory that it was a leak from the Wuhan Viral Institute, because they do some really dangerous experiments at that institute. They actually do what's called gain of function studies. They actually try to create viruses that actually have more function, greater transmissibility, and virulence. So it's it's kind of scary about, and they couldn't find a natural animal host. Well, they finally found in this raccoon, cute little raccoon dog, but in its genome, it clearly has the genome of the SARS-CoV-2 virus. So it's probably the strongest evidence we have that it really did come from that Wuhan meat market. And I don't even want to think about why raccoon dog meat was on the meat market, but the link is there. So next slide, Julie. So I wanted to briefly talk. We're just going to briefly talk because we don't. If we had another hour, we could really talk about the evidence. But just be aware that. And there are people, nurses even quote me, this Cochrane Review, which is a well-respected journal that really does meta-analyses, which a meta-analysis, most of you know, is basically an analysis of all the studies done, regardless of methodology. So, this Cochrane Review reviewed all the medical studies, or most of the medical studies, and their conclusion that masks don't work. So, immediately the scientists of the world took to this, and almost within a week, Suarez Weiser is the lead investigator editor for the Cochrane Review, and they came out with a retraction. So you just know that is simply that is, and her statement was that that statement is not an accurate representation of what the review found, and distributing masks don't lead people to wear them, which is why their effect on administration couldn't be confidently evaluated. So just know that there were general studies on general populations just are not going to be able to determine which patients were wearing those masks under their nose, like we've seen so many people in society, and whether or not they actually wore them in all important situations. So there are crucially, some really good studies like the Bangladesh study and this the cruise ship study. And I'm not going to go through the details, but which actually showed individual cohorts in a very significant reduction in contraction transmission and disease. Next study. There are actually evidentiary. Next slide. Evidentiary studies, though, that this is meant for distribution to you. I'm not going to go through all this, but there are clearly studies that basically showed, and including the second last bullet, at Mass General, they actually found in early 2020 that before mask mandates were introduced, that the infection rate among healthcare workers doubled every 3.6 days and rose to 21%. And after they mandated a mask, it quickly declined to 11.4%. So we clearly have enough evidence and significant convincing evidence that masks do work. And it's really more in terms of source control. And there are other theories on vacuolization, et cetera, with regard to a mask. So next slide, and I'll be glad to take questions on that. So how does it really spread? This is another lessons learned. When it first started, we didn't know this virus. We didn't know how it spread. So we basically kind of said, okay, wear a mask, avoid social gatherings, but wash your groceries, wash your hands, use hand sanitizers, and we all remember this. And it's kind of amazing that we've gone through all this, right? It's a sentinel event in all of our lives, but we didn't really realize at the time that it's not by fomite. Fomite is where you spread by contacting it with your hand on your computer, on your keyboard, and your food. It really minimally spread by contact. So all the stuff on hand washing, although hand washing is always good and hygienic, really weren't necessary. And we actually thought that it was droplets, right, that it spread, so that there's that 6 foot limit. And what we found was that it spreads more predominantly with aerosol particles, which are much smaller. And and you can actually the most recent change is that you just have to be in the same room and airspace with someone who has COVID to actually be at risk for catching it. So So we did learn this, but you know, at the beginning, we didn't know, and so I think it was completely justified that we basically did all these measures, the social distancing, et cetera, and also the fact that, you know, we shut everything down. We had to give science a chance to catch up. And I think that's really important. We lived through this. I lived through this during COVID, and you know, we had to do it. But and I'll talk about the shutdown in a second as well. And we realized, so basically on how it spread, we realized that the most important measures are masking, ventilation, and air cleaning. Okay, those are the keys, and also avoiding some high risk encounters with strangers. And I've got so many friends and family who've traveled, who've called me and said, I caught COVID. So, and travel is just that classic situation where you're getting in with people from all different areas. They're crowding you in on the boarding. They're crowding you in on the plane, and there's a limited ventilation, although it's good. So travel is like that high risk encounter, and also the getting together with a lot of people. So, next slide, Chelsea. So the next lesson learned is some lessons in communication. We realize that science is important, but at the same time, trust is equally important. And the general public lost trust in us, and it became, you know, a political issue. The public didn't know and couldn't base their decisions and their interpretations of what was coming down based on knowledge. So that we really realized that we needed to give kind of a basic course in virology to the general public, and give them the realization that infectious disease isn't intuitive. It grows exponentially, as we've seen. I mean, the studies that I've had, I was reviewing 20 to 30 studies per day that was coming out as we were learning. And we also learned about mutation, and that's a brand new lab skill, whole genome sequencing, that allowed us to detect mutations. And that's why we have all these variants, and that's why we can get more targeted vaccines. So since the people weren't prepared with this kind of knowledge, they weren't able to pivot. So when knowledge changed, and we had politicians willing to call out, you know, Dr. Fauci. I won't go into politics. I definitely don't want to go into politics. But, you know, I mean, Dr. Fauci is like the top figure in infectious disease probably in the world, and he was challenged by politicians. So, but if our patients and our population had that knowledge to be able to judge what was coming out and then make their informed decisions, it wouldn't have been like this. But because they didn't have this, it actually really created a lot of problems and misinformation that we had to deal with. So, and the last is just kind of an absence of a single trusted source of clear information. CDC kind of bogged down on this, and again, it was the political thing as well, and like Stacy mentioned, from an equity standpoint, some of our ethnic groups basically had their own reasons for doubting the information and not trusting the medical profession. So we learned all these things, and one of the things that came out of this was we created a huge emphasis on equity, and you're seeing how we benefited. We got Stacy in there to actually deal with equity, which is a huge point in public health. Next slide. So another lesson learned was the damages of the lockdown, and we're still digging out from this. Just to lock down, shut down schools, shut down businesses. So we realize the stress. When you have anxiety is defined as fear of the unknown, right? So we have this fear, and people were basically huddled at home, looking at their computer, not going out, being afraid of something that could kill them, and seeing on the news that people were dying, and not knowing how to prevent that. It's a natural that anxiety would produce, and not being outside in the sun, not having basically public interaction created a huge amount of mental health issues. The suicide rates tripled. depression in 70% of our population. So, and we're digging out from under that. Our children particularly suffered when schools were shut down and not being able to interact. Physical health has certainly been affected as well. Just the inactivity, the lack of our ability to do screening tests like colonoscopies, stress tests, cholesterol, blood tests. People weren't going out and doing any of these. And of course, the effect on our economy, God, it was huge. So, I mean, we really learned, and we probably the next time, I don't know whether we're going to have a huge lockdown. It'd be much more better to be targeted, okay? To target things. But that's based on our knowledge of the virus, of the disease and how it spread. So, we may yet do it if it's a global pandemic again that hits us, and God forbid. But it's much better if we knew this to do much more targeted studies. And you can see those countries: Taiwan, South Korea, Hong Kong, New Zealand. They had markedly low incidence of cases, hospitalizations, and mortality. And they did it with just masking, contact tracing, and strict isolation and quarantine, which are basic public health principles. So next slide. The next topic, and I'm going to probably end this because we really like to emphasize and give everyone the opportunity to ask questions so that we can talk about it, is we learn about the disease. We learned, and I remember when we first started out getting sick patients hospitalized and intubated, that number one, when we drew their blood, our coagulation tests were off the board, and it was crazy how high they were, higher than anyone with a blood clot in their legs, higher with anyone who had a pulmonary embolus. And what we learned is that the COVID vaccine produces an endothelial reaction in the small capillaries and small arterioles. So it really produced this microvascular thrombi. And when we took sections of the lungs of people who died from COVID pneumonia and subsequent COVID-19, the disease COVID-19, in the microcapillaries, we found extensive thrombosis. And what happens with thrombosis in the lung, with pulmonary emboli or thrombosis? It creates hypoxia. It creates a shunt, basically, and you can't correct that with oxygen unless it's super high. And that's why we had this. We developed those protocols, but we didn't know that at first. So we had people who dropped oxygen saturations into the 70s and 60s, but and we intubated them. So what we learned, though, is that these people actually did pretty well if we just give them super high flow oxygen. And so that's that term, happy hypoxia. These people were supremely or severely hypoxic, but they were happy. They weren't sick like we expect. But when we intubated them, we learned another thing. People were dying from what's VILI is ventilator-induced lung injury. So we learned that people who were intubated, who had otherwise healthy lungs, were dying from respiratory deaths, and we were presuming it was the COVID, but there was a significant component of VILI or ventilator-induced lung injury. So we stopped. We really minimized intubation, and that made a significant difference in mortality. It was at the beginning of the pandemic. If someone was intubated and put in ICU, they had a 99% mortality. They were almost always going to die, but we learned a lot. We learned we used remdesivir and some of the other agents and steroids as well. So those are really important. And then finally, from the disease, we're finding that there are a lot of subsequent thrombotic events, and thrombotic events like myocardial infarction, heart attacks, and stroke, even up to a year later. So we learned that this virus is vasculotropic. It really does affect and induce in situ thrombosis. So next slide. Okay, so we did learn another lesson learned. Even mild COVID can cause long COVID. And long COVID is this new disease, a third one over with the unhappy face, but with fatigue, like remember when people got mono, they just had no energy and they're still short of breath, and they have achiness and this brain fog. So we learned that you don't have to have severe COVID to get long COVID, and long COVID is miserable for these people. And we're still dealing with that, still trying to learn about this and realizing the long-term effects. So even mild COVID. So that's why it's important to we have to continue, for our patients' sake and our community's sake, to actually help to prevent even mild COVID. Next slide. And the next lesson learned is that COVID is seasonal, and we've had traditional coronavirus data. The coronavirus has been we've known about that for decades, and the coronavirus is one of the cold viruses. So we know the traditional coronavirus is seasonal, starts in early November and goes through end of April. So, this has been our existing experience from the data of infection and mortality and hospitalization for the past 3 years. Every year at the end of October, right around Thanksgiving, we'd start seeing the big peak, and it would peak around early January and come back down. So this is the behavior, what I meant by the behavior of the virus, and it naturally does this. It does better in cold environments. And some of the studies that I can supply you basically can show that for every degree latitude away from the equator, there's a significant incidence of COVID-19 that grows all the way up into the cold environment, which also substantiates the seasonal aspect. So next slide. And I think that's all I have right now. I did give you some time for questions, and one of the first ones I wanted to do is I think it's really important. We're part of why we're doing this and why we've addressed this talk on equity is why. It's why is it important? Why is equity important when we're talking about a pandemic like COVID-19? So I'm going to basically kind of ask Stacy if she could kind of elaborate on that, and that'll be our first question.
So why is equity important? Well, I think COVID was probably a massive realization for everyone in highlighting some of the underlying structural inequities that have existed for a long time. So I think, when we're looking at outcomes, case rates, hospitalization rates, deaths, and so forth from COVID, we're not really talking about biological differences between different races or ethnicities, right? Or probably not. There are some biological differences by age, but for the most part, we're talking about, and the reason that we're seeing such big differences in outcomes when we look at it by HPI quartiles, we're looking at really what are the underlying structural differences, what are some the systems that we have created in our society that are serving some people very well and others maybe not as well. And so we're looking at social determinants of health or drivers of health. There's lots of different terms for the various set of factors, but that's what the HPI index is a great tool, because it's a composite index that really takes into account a lot of those underlying variables. Unfortunately, because our systems are set up and we see so much structural racism that we're now more widely aware of, I think, due to the pandemic, there are a lot of our Black and Brown communities live in areas that are under-resourced and more challenged, in lots of the areas that we're trying to measure. And so therefore, we also see these disparities and inequities expressed when we stratify by race and ethnicity. So I'm sure, others have thoughts, but, feel free to add to the conversation. But I think that's, we're just using these variables as trying to stratify our data as really just proxies for what are these underlying drivers of health.
Thanks, Stacy. Alice, are there questions from the chat? Do you want to lob those at us?
Yeah, absolutely. Soteria, do you want to go ahead and jump on those, starting with Holly's question?
Sure, absolutely. The first one is, going forward, what precautions do you recommend at gatherings such as church services?
Well, I think if Stacy and Chelsea, I can if you don't mind, I'll address that. But yeah, it's really important. And this is one, remember the 3 important principles of avoiding mass gatherings. So it's important to realize that this is really a transmissible virus. The R naught is like 12, which is, R naught is how many people will one person infect with an infection. And that's actually, it's probably more like with the new XBB.1.5, it's probably more like 15, which is it's actually past measles as the most transmissible virus. So virus and disease. So it's really important, I think, for people who are symptomatic to test and to stay at home. And I think that's probably the most important thing with regard to that question in like church gatherings. We all worship, or hopefully most of us do. But it's important that if we're symptomatic, especially, that we stay home. So.
Yeah, okay, the next one is, do you feel that the advertisements and massive efforts at educating the public have increased vaccination rates, et cetera? Understand that the ROI is very difficult to demonstrate.
What do you think, Chelsea?
I think I'll hand that one over to Stacy.
Like a beach ball, we're passing it around. My opinion is generally it probably helped for a segment of the population, right? So when vaccines first came out, and probably I think that the mass advertising, when we don't tailor it to the specific concerns of particular communities, and when it's not culturally relevant, when we're not sensitive to the specific hesitancies that maybe some groups are feeling or the questions that they have, it becomes less effective. So, it seems like it was probably very effective at the beginning, but probably for the segment of population that was already more willing to get vaccinated to begin with. And so when we start working and talking about mass vaccination for subgroups of our population, like some of you have been participating in our COVID vaccine equity work groups, we really need to start thinking about where are people at now? So if they haven't been vaccinated, if they haven't vaccinated their children, what are some of the reasons why, and how can we address those conversations? And I think I may have seen someone here from UC Riverside Center for Healthy Communities on, maybe she dropped off, but they've done a great job at having some of these community conversations where we're actually having just frank conversations and allowing people a safe space to ask questions of experts and trusted messengers in their community, where they can really just kind of get some straight answers, and think about it some more. And that might just get them closer to accepting a relatively new vaccine. But I think that the communication needs to be a little bit more tailored at this point.
Yeah, I completely agree. And I think, a huge part of public health is educating our public. And that was one of the points I made. And especially when there's so much disinformation that was out there, and it became partisan, and people were throwing out, there's something called the Dunning-Kruger effect. And that's where people sometimes who have kernels of knowledge will then come out and speak like experts. And that I saw that all the time. So I think these efforts at educating were really important and necessary. But I agree with Stacy. We should have, and we tried to target. We like with African Americans, we try to target Tuskegee and the reasons for their distrust to the medical community, for instance. But yeah, I had to do it.
Just to add a bit onto that, I mean, I do know that CDPH has tested more positive messaging surrounding vaccines and COVID-19 treatments instead of using fear-based messaging, and that has been received well, and so really going that route of positive messaging towards these things would be ideal.
Well, I noticed that, and I noticed that lately some of the ads have a more kind of a, like you say, not fear-based, but more of a, not lighthearted. I don't mean to imply that it's being taken anything less than seriously, but it's kind of colorful and hey, we're all in this together and let's make this a pleasant experience sort of thing. So it's always difficult. Every organization goes through that, which side do you focus on? ultra positive or the negative ramifications. But yeah, I kind of asked that because I see all these colorful, bright ads, and I think it's interesting and they're attention getting, frankly. So, okay.
Good. Did you guys like, they're showing one commercial where all these people like they're throwing a ball and
Yeah.
dancing. And,
Yeah, that's the one I'm thinking of. Yeah. Yeah.
Did you guys like that?
Yeah, I think it's
Yeah.
cute. Every time it gets my attention. Yeah, I think it's
Funny.
cute and it has kind of a positive connotation with it. Yeah. Okay.
Okay,
Thank you.
we have one more. It's why do some people not show any symptoms of COVID if comparing against others of same good general health? Is everyone's immune system just that different? With common cold or flu, the symptoms seem to be pretty consistent across the categories. Can we just expect to live with COVID for the rest of our lifetimes?
Those are two different questions, but that's okay.
I just ran it all together.
Great question, and I'll field that. And I should have put this in as lessons learned, but in terms of learning about the disease. But what we've learned is probably up to 40% of people who actually contract COVID-19 are asymptomatic, we're really doing cohorting and controlled studies in terms of, because we were testing everybody, which I loved, and so we learned that there was a significant portion of the population who caught COVID who were asymptomatic, and as to why, there's a tremendous variability in terms of, we know that the COVID virus attaches with its spike protein onto our ACE2 receptors in our nasopharynx and oropharynx, in our mouth and nose. So certain people really have a lot better IgA to prevent this from, virus from attaching onto the mucosa. And there also is natural immunity. And we know this from neutralizing antibody studies with HIV. Some people just have these T lymphocytes that produce these neutralizing antibodies, and they're much more resistant. And that's why, we see partners who have HIV and one has HIV, the other, and they're intimate with each other, they don't catch it. So there's a huge amount of variability, and yes, it's going to be something we're going to see every season, so it's our job to keep surveillance up and to give you guys a heads up, because I think it's going to be seasonal, and hopefully it'll just be mutate itself back out to just being a bad flu-like illness. So.
Mike, I didn't write a question, but do you think as a culture we should move to a behavior similar to the Japanese, where we wear masks in all public places?
Yeah, I hope. Yeah, great question, and thanks for asking that, Ken. Because I think I wish I see a lot of people have learned from it, and we're also, and I think and that's why those countries had significantly lower rates at the beginning of this. They're clearly important mitigating factors, these masks, et cetera. So I think it's really necessary and important, and we're dealing with COVID fatigue in terms of the masks and the distancing, and people, I think, are kind of overreacting right now. They're deliberately. It just feels so good to go out without a mask, right? So.
I tell people that are wearing masks at the store, I walk up to them and I smile and I say, wearing a mask is a sign of intelligence.
There you go.
Everybody loves that. They go, thank you. And they might be the only one in line wearing a mask, including not me. But wearing a mask is a sign of intelligence.
Yeah, and simply, even if it's just for what we call source control. If you have a cold, put on a mask, so you're not spreading it to everybody. But
yeah. Well, like when I traveled, Dr. Sequeira, you said, "Are you wearing your mask?" And I sent you a picture. This is last year, but I sent Dr. Sequeira a picture of my goofy little cloth mask, and he said, "That's great. I think you need something stronger. Go in the gift shop and get a decent mask." So, I think people have to really be smart, like you are all saying, be smart about it and protect yourself to the maximum ability. If you're going to wear on an airplane, especially, get the N95 or the KN95 at least, right?
Yeah, for sure. I still remember that.
Yeah.
Allison, we need you.
Yeah.
We need you. Get a better mask.
You were very diplomatic in your response. You're like, you're going to need something a little stronger than that.
And in San Bernardino, we can be promoting the San Bernardino County Medical Society.
Yeah, well, we have, of course,
Yeah.
this mask with their logo on them. Yeah.
Let's
Yeah.
save it and put it in our medical museum.
Yeah. That's true.
I really think we need a COVID exhibit.
Oh, that's a great
in the medical
idea.
museum. So,
Oh, Debbie, we'll have to talk to whatever happens with our medical museum. We'll have to talk to Dr. Davidson about that. Great idea. Well, I don't see any other questions, and we are sadly at time here, but if anyone else has a quick question, now is your chance to raise your hand. Otherwise, we will thank you all so much, Dr. Sequeira and Chelsea Koski and Stacy Davis. We just really appreciate your diligence and incredible knowledge and expertise on this. And we really do look to you for this ongoing guidance. So you're talking about trust. It's wonderful to know that we can all go to your website or talk to you and really, really trust that information. So thanks for looking out for all of us, and hope everyone has a wonderful rest of your week. And we will have another webinar in this series, partnership with Department of Public Health, coming up at the end of April or early May. So please stay tuned for that.
and I wanted to end with thanking the Medical Society for, whenever I wanted to communicate something to the providers in our county, I called on Allison or Janice or Sequeira, and that we need to get this out to the providers, and they did, and promptly, and Hospital Association did the same thing with the hospitals. So that was really important. And so thanks again, and thanks for these continued efforts.
Well, we thank you as well. You're wonderful. It's a great partnership. And thanks everyone for joining us today. And we will look forward to seeing you all soon. Stay dry. Goodbye, everyone.